I've been staring at this MDM table for days. I know there's 3 elements. There's the number and complexity of problems addressed, amount and complexity of data to be reviewed and analyzed, and the risk of complications, morbidity, and mortality.
That's right.
This MDM table looks simple until you actually read it. Ebony, I know you can make it make sense.
That's right, and I got you, Rookie Rhonda. This is part 1. We'll break down the first column of the MDM table, which is the number and complexity of problems addressed. We'll learn the definition of key terms to help us understand, have more confidence in choosing the correct MDM level.
Okay, I have my CPT book and I'm ready. And before we even get into all of those keywords, can we talk about what a problem versus problem addressed actually is? Because I see that word all over the place and I'm not sure when it really counts.
Good catch. Understanding the difference between a problem and a problem addressed is important because only the problems actively managed during that patient encounter counts towards the complexity of problems for the MDM. A problem is any disease, condition, illness, injury, symptom, signs, complaint, or any other issue a patient has with or without a diagnosis. A problem addressed is a problem that the health professional evaluates or treats during the encounter. There must be documented evidence that the provider considered, evaluated, or managed the problem.
Oh, so not everything listed automatically counts.
Exactly. If it's just mentioned in the note but not evaluated or treated, is not considered addressed. Now let's look at how CPT breaks down those problems by level of complexity. We'll start with the simplest category, which is minimal problems. Minimal problem is a problem that does not require the provider's presence, but service is performed under the provider's supervision. A minimum problem is simple, minor, and does not require major decision making. Let's say a patient has a bee sting on their arm. The site is red, has a little bit of swelling and itching. The patient has no history of bee sting allergy. The staff member might remove the stinger and provide instructions for home care.
Oh, so like apply some ice, use some hydrocortisone cream, and stay inside the house type level?
Exactly. No prescriptions is needed and a full recovery is expected. A self-limited or minor problem is a problem that's short-term and expected to resolve without lasting effect. A self-limited or minor problem has a predictable time frame, not likely to permanently change overall health status, and may require minor supportive care. A patient who has no other underlying health issues comes in with nasal congestion, sneezing, and a headache.
Ugh.
A review of the patient's history, a limited physical exam of checking their throat, listening to their lungs, and they come with a diagnosis of seasonal allergies. No testing is performed. The provider advises the patient to use an over-the-counter antihistamine, a nasal decongestant, and ibuprofen or acetaminophen as needed. He instructs them to follow up only if their symptoms worsen.
So like take some Benadryl and stay in a house type level.
Exactly. The problem is common seasonal allergies with a known course and is not expected to cause lasting complications. A stable chronic illness is a long-term condition for which the patient is currently at their established treatment goal. A stable chronic illness is not worsening, minor, and does not require major decision making. Let's say an established 60-year-old patient is seen for a routine checkup. The patient has a history of hypertension. The patient reports that they have been compliant with their medication and the home blood pressure readings are consistently within goal range.
Okay.
So the physician reviews the patient's records, documents that their blood pressure reading in the office also hits their treatment goal. Then they confirm that there are no new symptoms or changes. The physician states the medication is working effectively and informs the patient to continue their medication regimen.
So you're saying as long as their pressure is not doing the electric slide, it's stable?
Exactly. Just nice, steady readings within treatment goal range. An acute, uncomplicated illness or injury is a recent or new short-term problem with low risk or morbidity. The condition is expected to resolve completely within a little to no risk of lasting functional impairment. Let's say a teen athlete twists their ankle during a game. They come into the clinic with mild swelling and pain, but the patient is able to walk.
Ouch!
The provider examines the ankle, maybe even order an x-ray. After the results, they determine that it is a mild sprain. The physician then recommends rest, ice, a compression wrap, and elevation of the ankle. They also recommend over-the-counter naproxen or ibuprofen and instructs the patient to follow up if the injury does not improve as expected.
So it's a short-term injury that'll heal up just fine with an ice pack, a couch, and if you stay in the house.
Exactly. It's new, simple, and low risk. Acute, uncomplicated illness or injury requiring hospitalization or observation is still low risk, but it is bad enough that treatment needs a hospital or observation setting. It is short-term, new or recent, low morbidity for treatment required, and little to no risk for mortality with treatment. An example would be a healthy 30-year-old patient who comes to the emergency department with 3 days of nausea, vomiting, and diarrhea. The patient is unable to keep down any oral fluids and has begun to have headaches and feel lightheaded. The provider orders an IV fluid and anti-nausea medication via IV to control the nausea and vomiting. The patient remains in observation for several hours, and once rehydrated and stable, they were discharged with meds and hydration instructions.
So it's not severe, but they can't just go ahead and go home right away.
Exactly. This one's still an acute, uncomplicated illness, but the dehydration made it unsafe to manage at home or in an outpatient setting. Stable acute illness is a problem that is new or recent for which treatment has been initiated, but now the patient's condition has improved and is now stable, even if the complete resolution has not occurred. For stable acute illness, the initial treatment has been given and has proven effective, and at this point may not have complete recovery yet. An established patient returns for a follow-up visit for a recently diagnosed migraine. The patient reports that after taking this prescribed pain medicine, the migraine, nausea, and light sensitivity has all improved. They still have some residual mild headaches, but overall, severe symptoms are gone. The physician reviews the patient's response to the medication, confirms that the treatment plan is effective, and documents that the patient's condition is now stable and improving. She advises the patient to continue monitoring their migraines and to use the prescribed medication as needed. They schedule a follow-up for a few months to reevaluate the migraine and discuss a long-term plan.
So it's new but now under control, right?
Right. Keep in mind that the initial visit was for an acute, uncomplicated illness, but now at the follow-up, the problem is reclassified as stable acute illness. It's still an acute illness, but now it is stable because the prescription medication has worked and the patient is no longer experiencing at least those severe symptoms.
Okay, that makes so much sense now.
All right, take a breath. We just broke down the first half of number and complexity of problems addressed. You're halfway through this column, and trust me, the next part gets real too. We've got more terms to unpack, more examples to break down, and that's where your coding confidence will go up. Keep your CPT books close to you and meet me in part 2 when it drops. Go ahead and share this with your coding fam and hit subscribe, because if you're learning, we're learning together.